The first exam is going to cover all A and P. I'm going to give you guys another packet tomorrow with a lot of the illustrations you guys are going to see. It's going to be diagnostic tests, and it's going to be about urinary retention. Those are the only elements we're going to cover on the exam. However, there's a lot of different medications that I'm also going to be talking about. Eventually, you guys have to learn, like, where does Lasix take an effect? Where on the nephron does it affect the nephron? Does it cause it on the convoluted tubules? What's Lasix known as? A loop diuretic. So what do you think it exposes its effect on? The loop of Henle. So very basic elements like that you guys have to know. ADH, anti-diuretic hormone. We talked about that, right? Remember in the previous chapter? So you guys have to know where that takes effect on the nephron, because that's where it acts on it. It acts on it in the distal tubules, in the collecting ducts. So those are elements that you guys have to know, and I'm going to be talking about them as I go through. So if you guys have any questions, raise your hand, and I'll be happy to explain anything that I can to you guys. And anything that's in red and bold, write it down. And I added some stuff to the PowerPoint that you guys don't have. Okay, so I added to it. If you see something out there, write it down. Ask me whatever you guys feel that is unclear, and we'll take it from there. My goal is to have all you guys pass. That's my goal. Okay, yes?
Are we taking the test on the entire chapter?
No. That's what I'm saying. We're only taking the exam from the starting of the chapter up until where hydronephritis or nephrosis begins. This is chapter 10, right?
Yes.
Yeah. So we're going all the way from the beginning, all the way up to up to 450. Let me see. We're going through urinary tract infections as well. Urinary obstruction. Oh no, not urinary obstruction. I'm sorry. Yeah, so we're going all the way up till page 457.
So which one is the last thing we do? So we're doing 2 tests?
We're doing 3 tests.
Okay.
We're doing 3 tests, folks. We're doing 3 tests. Listen to me. Listen to me. On this chapter, we're doing 3 tests. The first test goes up to page 457, I think. Is that what I said? We're stopping at 457. We're stopping there. We're not talking about hydronephrosis. We're not going to be doing that for this first exam. The next exam is going to take it from hydronephrosis all the way up to whatever kidney disease. The last test is going to be on renal failure, dialysis. You guys see how we're splitting up the chapters now? So so look, Miss Jessica, the first exam is going to be from the beginning of the page of the chapter all the way up to page 456. It's going to cover all that. A&P, diagnostic tests, different catheters, urinary retentions, UTIs. That's what it's going to cover. Okay, from the second exam is going to cover from page 457 to I forget what page, but up until we begin renal failure.
So we start at urinary infection?
Look guys, listen. Let's not get ahead of ourselves, okay? The only thing that you guys have to know for now is we're starting from the beginning of that chapter all the way up to page 456. Okay? I'm gonna cover everything that that's gonna be discussed in the exam. Okay?
Just to clarify, we're not following the syllabus.
What's the syllabus say?
451.
No, because the exam, see this is the thing guys, the exam talks about UTIs. That's what it says on the syllabus, and I wish you would stick to that. But the exam has things about UTIs. It has things about these elements right here, urinary obstructions. It talks about that, so that's why I'm including it in the PowerPoint. Okay?
So we're going to read urinary obstruction.
That's correct. Yeah.
So we start here.
All right, let's begin, guys. All right, so we spoke about this before, folks, but let's make sure that you have to know this because I'm gonna test you on it on so many different ways. You guys are in term 3, so when you guys do an NLN, wait, term 3, right?
Yes.
When you guys do an NLN for this term, you guys have 3 NLNs. One for pharmacology, one for physical assessment, which is not gonna count against you guys, and one on adult health, meaning everything we covered from term 2 to term 3. I'm expecting 60s for the adult health, high 50s, it's okay. I'm expecting high 60s to 70s for the pharmacology. Okay, you guys might freak out, we haven't really covered pharmacology. Well, it so happens that every time I do a chapter, folks, I always implement certain medications. I talk about certain elements and what's unfortunate is that in cardio, you guys were kind of gypped, right? So I'm gonna be giving you guys a PowerPoint and a lecture on the cardiovascular system because there's a lot of medications that I want you guys to be able to figure out. In particular, your ACE inhibitors, your beta blockers, your calcium channel blockers, all those cool medications that we probably haven't talked about, but we will. Okay. All right. So functions of the urinary system. You guys have to know this. Essentially, everything we ingest in our body, we eat it, our intestines break it down, and through the venous system, they send it throughout our body, and we utilize those elements. Sometimes those elements, though, we have byproducts, such as urea. You folks know what urea is? Okay? Or it's a breakdown product of proteins. Okay, so when we talk about something called nitrogenous waste products, that's what I'm talking about. All the byproducts of when we break down food elements, they go into our bloodstream and we need to get rid of them. How do we get rid of them? Through our kidneys. Our kidneys excrete all those elements. So excretion of waste products, regulation of water, electrolyte and acid-base balance. Now, when it comes to regulation of water, which hormone influences water? Which one? Okay, ADH, yeah. ADH more primarily, you know why? Because aldosterone deals more with sodium. So we're talking about which hormone influences water retention or water excretion, it would be ADH, anti-diuretic hormone, also known as vasopressin. Please know that. ADH, also known as vasopressin, 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 because it presses or it constricts the blood vessels. So that's how it regulates water. Electrolytes. Okay, sodium, potassium, magnesium, chloride, all those elements, folks, are also regulated by the kidney. So you have to know that. Electrolyte imbalances. So understand that the kidneys maintain the electrolyte balance at its normal or therapeutic level. Lastly, the acid-base balance. Which acid-base balance are the kidneys responsible for influencing more? Respiratory or metabolic? Metabolic, right? So we're talking about metabolic. Is it acidity or is it alkalinity? What is it? No, guys. No. The kidneys are actually responsible for excreting something called HCO3, bicarbonate. So when we're talking about the respiratory system in term 2, can you guys see that okay? You guys see that? Okay, we have respiratory, we have metabolic, right? Do you folks remember when we were doing the ABGs and we talked about the pH being 7.35, 7.45, then we had something else, the CO2. Remember that? What does CO2 represent? Acidity. CO2, it's supposed to be between 35 and 45, but this represents acid. It says CO2 acid, so this represents acid, right? The CO2. This is controlled by which system? The respiratory system. You folks remember that? Okay. So yeah, the respiratory system is responsible for getting rid of or retaining CO2. Does that make sense? You guys remember that? Okay, if you don't remember it now. Since it's responsible for regulating the CO2, if you have too much CO2, you have too much acid. If you don't have enough CO2, you have a little bit of acid. That's how this influences the pH balance. However, sometimes your illness doesn't only affect the respiratory system. It affects what we call the metabolic system, or anything that's not the respiratory system. In this case, we're talking about the kidneys. So when we talk about HCO3, also known as bicarbonate, bicarb, also known as base. Okay, does this sound a little bit familiar? Okay. When we talk about HCO3, the system that regulates that is which one? Renal, yeah, the kidneys. And this is between 22 and 26. So yeah, this one represents bicarb base, okay, or alkalinity also. And this is controlled by the kidneys. How many of you guys are lost? Good. I'm not good, but I'm glad you guys are telling me. So let me make this a little bit more easy, okay? If we're talking about acid, the pH is something that we all have to be familiar with. The potential of hydrogen, that's what pH stands for. Hydrogen is an element, a very small element that's in our body that it needs to be in a therapeutic level. If there's too much or too little, our pH changes. If it goes too low, it becomes acidic. If it goes too high, it becomes alkalinic or base. That's just what it's called, right? The lungs, when we breathe in, what do we breathe in? Oxygen. When we breathe out, what do we breathe out? CO2. So see, that's how the respiratory system is responsible for the CO2, the acid. The kidneys, however, are responsible for the metabolic system, or the alkalinity. Remember I talked about the three elements that regulate pH? Your buffers, your respiratory system, your lungs, and then if those fail, then you have the kidneys. The kidneys can actually regulate it by either giving out more bicarb, which is going to raise the alkalinity, or withholding bicarb, which is if there's no bicarb, the other one goes up, acidity. Does that make sense? So that's how the kidneys actually regulate acid-base balance. If your kidneys are damaged, if you have renal failure, meaning the nephrons are damaged, and the responding elements of the nephron aren't secreting what they're supposed to be secreting, or they're not being able to reabsorb what they're supposed to reabsorb because it's damaged due to renal failure, you're not going to be able to regulate your water, you're not going to be able to regulate your electrolytes, and you're not going to be able to regulate your acid-base balance. Okay, does that make sense? If somebody has renal failure, let's say their kidneys are damaged, the nephrons, they're all dead. You're like George Lopez before the wife gave him the kidney. What happens to your fluid? If you can't, again, what's the responsibility of the kidney? Does it excrete? It excretes it, right? I mean, it chooses to retain it as well, but it's supposed to excrete it. We're supposed to make urine. What happens if you can't excrete it? What happens to your retained urine? Oh, actually, you're not retaining urine. You're not producing urine. Edema. Does that make sense, folks? You develop edema. What happens if, again, let's talk about potassium, because potassium is the most important one. If we eat a potato, we eat a banana, it's got potassium in it, right? Our kidneys are responsible through the nephron to say, all right, we're gonna absorb this much, oh, it's too much, and then we're gonna excrete some of the rest throughout those tubules. That's what the kidneys do. That's what the nephrons do. So if it can't even absorb it, or if it can't, let's say, excrete it, what's gonna happen to the you're gonna have some type of either hypokalemia or hyperkalemia, depending on where the issue's at. Does that make sense? That's why you have electrolyte imbalances. You guys know anybody that's on dialysis? Yeah. Okay, somebody that's on dialysis, what do they look like? Their skin is very darkly pigmented in certain areas. They tend to swell up, edema. They tend to be very lethargic. Their blood pressure goes up. Why would their blood pressure go up?
They're retaining all these fluids.
They're retaining all these fluids. Why do they suffer from hyperkalemia? They cannot excrete the potassium. They can't. It's in the bloodstream because you ate it, right? You eat the banana, and the capillaries pick it up from your GI system. And now it's in your blood system, but you have to remember, the kidneys are responsible for saying, hey, this is just enough, or it's too much, and we're gonna excrete it by making urine. We're not making urine. And what happens to the acid-base balance? It also goes ARI, it also goes abnormal. Does that make sense? Because it can't produce the pH or the bicarb, or the alkalinity to regulate things. So that's how those three elements are affected if you have some type of renal disease. Does that make sense, guys? All right. When it comes to kidneys, we have two of them, okay? We have two kidneys. Where are they located? Something called retroperitoneal. You guys have to know that word. Retro, behind, peritoneum. Peritoneal is pertaining to the peritoneum, the abdominal cavity. So it's in the back. That's where they're at. You have two kidneys. Okay, you guys have to know that each kidney has about 1 million nephrons. Write that down. Each kidney has about 1 million nephrons. That's a total of how many?
2 million.
2 million nephrons. Your kidneys, your body only needs about 500,000 to function. 500,000. You only need about a quarter of that. You only need about 500,000 nephrons to function. And you folks know that the nephron is the functional unit of the kidney, right? When we talk about, let me give a good example. When we talk about the brain, okay, what's the functional unit of the brain? The neuron. The neuron, right? The nerve cells. So when we're talking about the functional unit, or the cells that are responsible for the function of the kidneys, they're the nephron. And you folks remember the nephron, right? Bowman's capsule, glomeruli, tubules, all that stuff, which we'll talk about again in a bit. So you guys have to know that the nephron is a functional unit of the kidney. Again, how many nephrons does each kidney contain? 1 million. How many do we need in order to function? About 500,000. Okay, that's why some of us, we do a little bit of this, we do a little bit of this, a little bit of that. Whatever we do, eventually we can still tolerate a couple of years without going into renal failure, because while we're cleaning them off, we only need about a quarter of them. Does that make sense? Or we're drinking a lot of Coke. Drinking a lot of Coke, folks, kills your nephron. I still drink Coke all the time. All right, so urine composition. This is something very important you guys have to know. This is talking about the characteristics of the urine, okay? And a cup of urine, what's it supposed to have inside? It's supposed to have virtually nothing but water. Okay, it says that 95% of urine is water. All right, you guys have to know that. 95% of urine is water. You guys ever hear of some people drinking their own urine? Okay. They do. Like, what's his name? Marquez? Marquez, before he knocked out Pacquiao, what did he do? Drinking urine. And before he got beat up by Mayweather. But either way, he drank urine. Okay, he drank urine either way. So, because it's 95% water, and there's some belief that it's got these, it's not true, guys. You can't, let's say you get lost in the forest or something, or in the desert, let's say, and you need to drink, you're really thirsty. If you drink your own urine, if you drink too much of it, you're gonna die. Okay, because it's got all those waste particles that you don't need. So anyway, even though it's 95% water, the remainder is something that we call nitrogenous wastes and salts. You guys have to know that word. Yes.
Did he like chill it?
I don't know. When he drank it, there was steam coming out of it, so it's probably just freshly brewed.
Yeah, it's supposed to.
Oh, the first urine of the morning? And how would you know, Miss Kitali? Folks, 95% of urine is it's water. 95% of piss is water. 95% of urine is water. 5% is that waste product that I'm talking about. Every time we eat food and our body breaks it down, and the cells inside of our stomach, they absorb it, and then our bloodstream picks it up, right? So all those elements that we don't need, that, once we've met that therapeutic level, our kidneys are responsible through those little blood vessels, the glomeruli. It's supposed to filter them, push out with what we don't need, and in the tubules, our capillaries, our peritubular capillaries, which are the blood vessels around it, are supposed to reabsorb what's needed and let go whatever's not. Does that make sense? Okay? So 5% of those elements, folks, in urine is waste products, stuff that we don't need. There's some things that you're not supposed to find in urine, okay? Nitrogenous products is one of that you should, and electrolytes is another one, or salts. That's what it means by salts. However, if you find the following elements in urine, there's something going on. Let's talk about those real quick. Albumin. Albumin is a protein. Okay? It's a protein that's responsible for fluid regulation. And we'll talk about albumin later on. Oh no, did we talk about albumin already? GI, that's right, GI. So albumin, folks, and let me explain what albumin is real quick. I'm gonna use a really weird analogy, but it's gonna help you guys memorize it. You guys know what this is? You guys know what that is, right? Don't repeat it, but you know what that is. Oh, why are you taking a picture of it?
Why are you standing under it? Look.
Okay, so you know what this is, right? All right. You know what this is, right?
Oh.
You know what this is, right? It's water. Okay, so you know what this is, you know what that is, right? Just the words. Just the words. You get what I'm saying, right? What does a pimp do to this? He has to keep him on check, right? Okay, listen to me, guys. Listen to what I'm telling you because you're gonna memorize what albumin is with this. A pimp. I know you guys are recording me. Too bad. A pimp regulates his women. Okay? Albumin does the same thing to water. You need enough amount or a strong enough amount of albumin, pimp, to control his water. Okay? If we're all albumin in here, there's a lot of us. There's a lot of that in here, right? So we can have a lot of water in here. It's okay because we keep it in this compartment because there's a lot of albumin. Does that make sense? However, if we throw half of you guys out and we have the same amount of fluid, we can't keep our water in check. Does that make sense? So what happens to that water? Well, no one's telling it. Well, there's not enough of us to say you can't go out that door. So what ends up happening is the fluid that's supposed to be inside of our blood vessels, the plasma that's supposed to stay inside of our blood vessels all throughout our body, it doesn't stay there if you don't have enough albumin. If you're getting rid of albumin through your urine, you don't have enough fluid inside your blood vessels. They go outside into the interstitial fluid, hence you develop edema. Does that make sense? You guys have to know that. If you have low albumin levels or low pimp levels, okay, the water can't be regulated and it goes outside of where it's supposed to be. Does that make sense? Yeah, so if I have edema or ascites is fluid in the peritoneal cavity. If I have those two, the fluid's not where? It's not in my blood vessels where they're supposed to be, right? So it's somewhere else. Is my albumin high or low?
Low.
It's low because if the albumin is low, it can't tell the fluid, it can't restrict the fluid as to where to and where not to go. It can't keep it in check. If there's a little bit of albumin, it can't keep the fluid in check. Hence, it's supposed to be, you guys ever hear the term intravascular fluid? Okay, that's what it is. Intravascular fluid, what's inside the blood vessels, there's a certain percentage of water that's supposed to stay in there. If you don't have enough albumin because you're pissing it out, because you're getting rid of it through your kidneys when you're not supposed to, you can't keep your fluid regulation in check, hence you develop edema. Does that make sense? All right. Now, if your kidneys are supposed to utilize that albumin, which is a protein, right? It's supposed to utilize it in our body. And if it's not working, it's going to be dumping out all that albumin, okay? So it also happens with something called nephrotic syndrome, meaning when your kidneys just stop working adequately, your albumin is getting rid of in your urine, and you develop edema as well. So two elements that will cause edema, low albumin or nephrotic syndrome, okay? And we'll talk about that in a little bit. But what I want you guys to remember is that if you have low albumin, where does that water go? Interstitial fluid. Okay, your body can't be regulated, it can't be checked, and it goes outside of the blood vessels to other areas. Any questions on that? Okay. I'm gonna erase that real quick. In case somebody comes in. Any questions so far? Anyone offended by the pimp remark? So, it talks about urine abnormalities, folks. We're not supposed to have these elements inside urine. Albumin, which is a protein which regulates fluid balance, right? Glucose, you're not supposed to have sugar, and we just talked about that, talking about the diabetes Okay, if our body is getting rid of glucose through our urine, that means that we're hyperglycemic. There's something going on. So we're not supposed to have glucose in our urine. Erythrocytes. What happens if there's erythrocytes? That means we're bleeding somewhere. Okay. Ketones. We're not supposed to have ketones either. That means that you're hyperglycemic. You're developing diabetic ketoacidosis, right? And you're not supposed to have leukocytes. What happens if you have leukocytes? Infection. That means you have some type of infection in there. If somebody has a UTI, it's not uncommon to see leukocytes in their urine. Not to see them, but to have them once you test for it. Does that make sense? All right. Recap real quick. We've only done the first slide. When it comes to how many kidneys do we have? Let's start off easy. Two. Where are they located? Retroperitoneal. Good. That's all good stuff, folks. You guys have to know that for the NCLEX as well. How many nephrons do we have on each kidney? Okay. How many do we need to survive? 500,000, right? What percentage of urine is water?
95.
The 5% that's not water, what does it include? Waste products, nitrogenous waste, and salts. So you guys have to know that. Let me see what else. Which part of pH do the kidneys regulate? Acid or base? Base. Remember, acid is what, guys? CO2. You have to remember I told you in respiratory, CO2 equals acid. I said that for a reason. CO2 equals acid because that's your lungs. Your lungs regulate CO2. Your kidneys do not. But your lungs do. They regulate CO2. The other one is the kidneys, metabolic. So your base, your HCO3, your alkalinity, your kidneys are responsible for regulating that. Okay, you guys have to know that. What does albumin do? It pimps the hose. Okay. What does it do? It regulates fluid balance. How specifically?
By checking them.
By checking them. By making sure that if there's got to be enough albumin in order for it to regulate and keep the water where it's supposed to be. Okay. If you don't have enough albumin around, it's going to walk out that door. Bless you. It's going to walk out that door. It's going to go outside that blood vessel and go into the interstitial fluid. Hence, you'll develop edema. All right, you guys have to know that. All right, let's talk about the functions of the renal system. I'll provide you guys with illustrations of this in a little bit. The integumentary system, folks, we talked about hydration, right? So that's how it regulates, how it affects the integumentary system. You don't have to copy this down, but it says the urinary system compensates for water loss due to sweating. The kidneys and skin both play a role in vitamin D production. So if you're out in the sun or you're out working out and you're sweating a lot, you're getting rid of fluids. Hence, your kidneys will not excrete as much fluid. Does that make sense? A skeletal system. The kidneys and bone tissue work together to control plasma calcium levels, also by excreting them and not. Muscle controls the urine elimination from the bladder, meaning the contraction of the urine. Getting rid of the bladder, getting rid of the fluid of the urine, it's controlled by muscular contractions. Nervous system, it of course tells the body to excrete the urine. Endocrine system, we talked about aldosterone, ADH, right? So those influence urine retention and urine excretion. Cardiovascular system, the kidneys specifically can regulate the blood pressure. If your volume in your body is too high of fluids, your blood pressure is going to go up. If it's too low, your blood pressure is going to go down. Does that make sense? Your lymphatic system, the kidneys control extracellular fluid, volume and composition, including lymph. We're just talking about the fluid that's circulating in the lymphatic system, guys. Digestive system, it says the kidneys compensate for fluid loss by digestive system as well. Respiratory system, the kidneys and the lungs work together to control the pH of the internal environment. That's what I was talking about. Okay, the lungs do what? They control which element? CO2, also known as the acidity. And the kidneys regulate which element? The HCO3 or the bicarb. And then reproductive system, it says the urinary system in males shares common organs with the reproductive system, meaning the ejaculatory ducts, meaning how the man ejaculates, they're shared by the urethra. Okay, that's what it's talking about. So the kidneys, folks, are very important, is what my point that I'm trying to get across. Let's talk about, now this is the nitty-gritty stuff that you guys also have to know for the exams. When we talk about the kidney, this is one cross-section of the kidney. The outer surface, folks, is called the fibrous capsule, or just the capsule. You guys have to know that. Inside you have something called the renal papilla. That's nice to know. You do have to know what the calyx is. The calyx is like the cup. Like these little cup elements right here that are in this body that collect the urine and hence take it down through the renal pelvis, which I'll talk about again in a little bit. You have the renal column, also nice to know. Medulla. Medulla you have to know. It's a little element that looks like a pyramid. Upside down pyramid right here. That's called the medulla. So this is the medulla. Where's the cortex? This space right here. This is the cortex. These things you do have to know, folks. When the urine is produced, the nephron is somewhere in here, and it's the tubules actually extend down to the calyces. They dump out urine in here. It takes it to something called the renal pelvis. Okay. Then it's bringing the urine down to something called the ureter or the ureter. Does that make sense? Okay. These are of course the renal arteries and renal veins that are responsible for keeping the tissue of the kidney alive and bringing back its waste products. Mess with the slide. All right, and this is another little illustration. What's this? This is the medulla. This is the medulla right here. What's this part right here? That's the cortex. This is actually cut off so you can't see it. This part's supposed to go all the way over here. But what's this general area right here? The renal pelvis. What's this portion down here? The ureter, the ureter. Okay. All right, good. Now, when we talk about the nephron, folks, the nephron is inside, well, there's several of them. How many on this kidney?
1 million.
1 million, right? And this is how you see it. This is the nephron, and the little capillary system, or the afferent or the efferent blood vessels, they meet at the glomeruli, which we'll talk about again in a little bit. And that's how it produces its urine, it reabsorbs, it excretes certain elements, and then it dumps the urine in the calyces, hence bringing it down to the renal pelvis, down to the ureter. And this is the nephron. The nephron's a very complicated little structure, folks. You guys have to know it. I'm gonna test you on it. I'm gonna make a quiz that looks very similar to this, and you guys have to label it, okay? We have the afferent arteriole, which is a blood vessel that's going inside. This is what's, all the elements of digestion that we talked about, all the elements that our body's supposed to excrete and turn into urine, they travel through the blood vessels, through the blood, through the plasma part, and it brings it in here. And that's how it regulates it. Some of it's supposed to be dumped off, some of it's supposed to be reabsorbed. So you have a lot of blood vessels surrounding the tubules. So it goes to the glomeruli, Bowman's capsule, okay, proximal tubules, loop of Henle, distal tubules, and it becomes urine. You notice how inside the tubules, folks, there's these little specialized cells. As the fluid is passing by, those cells are reabsorbing what it needs and leaving alone what it doesn't need. So when you talk about like potassium or sodium or albumin, whether it's absorption or excretion, it happens through there with those cells. Again, where's ADH? Where does ADH affect the nephron? At the collecting tubules. Write that down, folks. ADH, I don't think the book talks about that, but ADH affects the tubules, affects the nephron at the collecting tubules. Yeah, ADH affects the nephron on the collecting tubules. So ADH, collecting tubules. What element is not supposed to be in urine? Albumin. Glucose.
Proteins.
Proteins, albumin, good. What else? Huh? Yeah, erythrocytes, leukocytes. Good, good, good. If you have erythrocytes in your urine, what does that probably mean?
Bleeding.
Bleeding. If you have leukocytes, what does that probably mean?
Infection.
Infection, usually with UTIs. All right, good. You guys, when I'm quizzing you guys on stuff like that, that's like the important stuff that you guys have to know for the exam. So you guys are doing well so far. All right, so the nephron structure. This is just a different looking nephron, folks, so don't get confused. It's got the same elements that any other nephron has. Okay, you guys see the glomerular capsule, or the glomerulus, and the glomerulus, the proximal convoluted tubules, the loop of Henle, which is not labeled, but it will be on the next slide. You have your afferent, efferent arterioles. You have your distal convoluted tubules. You have something called the interlobular vein. That just picks up other elements and takes it to the heart, okay, when it no longer needs it. And this is the lower aspect of it, the loop of Henle, okay, the artery aspect of it. And it kind of gives you an example, folks. According to the, while this is embedded inside the kidney, inside the cortex and the renal pyramid, it kind of lets you know where it's at. So up until this location, it's in the cortex, okay? Then as it travels down further, it goes into the renal medulla. Eventually, the collecting duct empties out into which part of the kidney? The one that looked like cups. The calyx. The calyx. So if I ask you guys, where does the collecting tubule dump its urine into, or its formed product? You guys say the calyces or the calyx. Okay, that's important for you guys to know. This is a better illustration, folks, of what the actual glomeruli looks like inside of Bowman's capsule. Okay, you have the efferent blood flow, of course, it comes inside. And notice how it's pretty thick relative to the other elements here. It's highly pressurized. If I ask you guys which technique or by which means do all the elements inside the glomeruli go into the capsule, into the tubules, it's filtration. It's highly pressurized, and it goes through a semi-permeable membrane, where if the elements are the right size, they'll pass on through. Of course, if there's some type of damage here, then you'll have some other elements that are not supposed to pass by, hence your albumin, your proteins that are a little bit bigger. But if you have damage inside the glomeruli, okay, this is damage, so you have bigger gaps in which those elements also pass on through. That's why when you look at the urine with proteins, wait, that means there's something wrong with this. Does that make sense? Okay, and here's another little illustration of sodium and water reabsorption. It talks about sodium and potassium are reabsorbed by active transport. You guys remember active versus passive transport? It just means that we're requiring energy. You don't have to know it, but we're switching off. We're taking off some sodium, we're giving off some potassium. That's usually how it works. We have the sodium potassium channel pumps. That's what they're called. And through the tubule, okay, this is where you have sodium, potassium, chlorine, phosphorus, sodium, all the bicarb. This is where you have all those elements. And depending on what our body needs, it reabsorbs some elements, and some elements that it doesn't need, it lets it go through. Does that make sense? I just want you guys to get the gist of that. That's how the electrolytes are reabsorbed in the system. Functions of nephron components. Let me just talk about this real quick, guys. Talks about, you guys know what this is. The glomeruli, the little network of capillaries, of blood vessels. Filtration, right? They filter out all the components. It talks about the proximal convoluted tubule, the next portion. That one's responsible for reabsorption of glucose. You see how glucose is not supposed to be in the urine because it reabsorbs it into the body. Okay, glucose, amino acids, creatine. Creatine is something important that you have to know. Okay, write that down. Or creatinine, which we'll talk about in a bit. Lactic, citric, uric, ascorbic acid. All those elements, folks, are being reabsorbed into the system. What I was showing you guys right here, look. They're being reabsorbed in the proximal convoluted tubule. When you get to the descending, or the loop of Henle, that's where absorption of water by osmosis occurs, just meaning the shift of fluids. Now we're reabsorbing water. Also, reabsorption of sodium, potassium, and chloride ions by active transport. You guys remember when we talked about Lasix being a loop diuretic, because it acts upon the loop of Henle, right? So when you actually, and then also if you're going to give somebody potassium, for it to be absorbed, which the ascending loop of Henle is responsible for reabsorption, you give them potassium chloride. You guys remember that? When you give a medication, when you give that medication potassium, it's not just potassium, it's potassium chloride. The reason why you have both of them is because in this particular area, the body likes to reabsorb potassium and chloride. It likes those elements. So that's why they give you potassium chloride, so it can be absorbed in greater quantities. You guys don't have to know that for the exam, but that's just how it happens. The distal convoluted tubules, reabsorption of sodium ions by active transport. So if we talk about, look, notice how it talks about reabsorption of sodium. Sodium, what hormone is responsible for the reabsorption of sodium? Aldosterone. So if I ask you guys, where does aldosterone take its effect on the body?
Distal convoluted.
The distal convoluted tubule. So now we know two of them. Okay, we know that ADH works on the collecting ducts. We know aldosterone works on the distal convoluted tubules, and that Lasix works on the loop of Henle. Does that make sense? Aldosterone works on the distal convoluted tubules. Because we talk about reabsorption of sodium. So if we talk about what does aldosterone do? Well, it helps with the reabsorption of sodium. I don't know if you guys will let me see. Alright. So if we think about the nephron, guys, you guys see the nephron? Yeah. Okay. We know that we have a lot of blood vessels in here. They come in. We have the afferent, the efferent arterioles, right? And on the outside, you guys remember the other illustrations? We had a bunch of blood vessels all around. You guys remember that? Yes. Alright, so initially, our body needs sodium. It needs potassium for its pH, for its therapeutic level. Does that make sense? We need enough of it, right? So that's what the proximal convoluted tubule is for. It just absorbs everything that we need. It keeps most of it. As it starts going through, little receptors inside the nephron, inside our blood vessels, inside our brain, they all message each other and they say, wait, we need a little bit more or get rid of a little bit less. As that's happening, it so happens that aldosterone affects this particular area. When that hormone is released, aldosterone is in charge of reabsorbing the sodium. So it happens here because in the distal convoluted tubule, that's where sodium is reabsorbed. So aldosterone taking effect in the distal convoluted tubule. Okay, ADH, antidiuretic hormone. Look at the last part, reabsorption of water by osmosis. We talked about that already. We said that initially up here somewhere, right? But remember, the body needs its water. It's gonna do like what it's gonna normally do. However, at this point, it's taking out what it doesn't need and it's reabsorbing what it does need. So if we're talking about the collecting duct, this is where the reabsorption of water by osmosis occurs. Well, ADH, which doesn't have anything to do with sodium, is going to work on this area because this is where the fluid's at. So ADH tells this particular area to regulate its flow output. Does that make sense? What you guys have to know is that aldosterone, distal convoluted tubules, ADH, collecting ducts. Any questions on that so far? You guys good so far? I'm giving you guys a lot, but it'll be easier when we talk about it in further detail on the PowerPoint. May I switch the slide? Okay. All right, we have how many ureters? Two, one coming from each kidney, okay? So we have passageway for urine from the kidneys to urinary bladder. We have one bladder, of course, temporary storage pouch for urine. Urethra, we have one. Carries the urine by peristalsis. That's the muscle movement that I was talking about. From urinary bladder out to its external opening, or its meatus. You folks know what a meatus is, right? M-E-A-T-U-S. Please know what a meatus is. And that's this illustration right here. So, we have the kidneys. What are these elements up here? The adrenal glands. Yeah, the adrenal glands. So, the kidneys produce urine here. It takes it through its renal pelvis, which you can't see. Okay? And then it comes down through the ureters. And then it goes inside the urinary bladder. Does that make sense? Okay. Inside the urinary bladder, folks, we have something called rugae, very similar to the inside the stomach, and it helps expand. And once it expands, it sends a message through the nervous system to the brain that, hey, I'm full, and that's how we micturate. What's micturate? Peeing. Micturation is urinating, that's right. And then the urethra goes to which part? The meatus. Good. Here's the illustration that you guys have in your book. You folks notice this grapefruit looking like thing? This is a prostate gland on males. Okay, only males have this, by the way. If you have an increase of the size of a prostate gland, what's it going to constrict? Your pee? Your urethra. Your urethra. It's going to constrict your urethra. So if I'm 80 years old and I have an enlarged prostate, and when I sit down and pee, what's my urine consistency, or what's my voiding pattern going to be like? It goes a little bit. Okay. Yeah, you only go a little bit. You dribble a little bit. You have high frequency. You want to go again, but you can't. Okay. That's essentially what's happening when your prostate is enlarged, because it's squeezing on the urethra. Does that make sense? May I switch slide? And here's a couple of other illustrations. This is the difference between the male and the female. The female, of course, does not have a prostate gland. Okay. All right, laboratory and diagnostic examinations, guys. Let's talk about this real quick. BUN, yeah, blood, urea, nitrogen, really important for you guys to know. And you have this on your PowerPoint, but I also added some elements to it. So when we're assessing the blood, urea, nitrogen, this is a blood test. This is a blood serum test that we take from the antecubital fossa, and we assess it. We send it to the lab, and it lets us know how much urea and nitrogen is inside the blood. Now, how does urea and nitrogen get excreted? Through the kidneys. So if the kidneys aren't functioning, what happens to the BUN?
The levels are up.
The levels go up. The levels go up. That's really important for you guys to know. It says that urea and nitrogen is produced when protein gets broken down. This is what I was talking about earlier. The kidneys secrete it, but sometimes it's also seen in dehydration. So what I'm trying to say by that is this. BUN is a good indicator that there might be some type of renal issues. However, by itself, it doesn't mean much. If it's elevated, it could be that we're dehydrated. Okay? So if you only have a BUN sample being presented to you and it's elevated, the BUN by itself doesn't let us know that there's renal failure. It's not a good predictor of that. You need something else. I'll talk about that in a bit. It's called creatinine. But it does go up though if the patient's dehydrated. So please know that. If your BUN is up, it may be because you're dehydrated. Now we present BUN, it's elevated, and we present something else called blood creatinine. These two tests, folks, are done together in conjunction with one another. If they're both elevated, kidney failure. It could really indicate that. Blood creatinine, molecule waste from muscle metabolism. Okay? Meaning when muscle is being used, when it's broken down, it's excreted through the kidneys. Every time we work out, folks, you feel, I know, folks. Every time we work out, how do you guys feel? You guys feel sore, right? Certain elements, lactic acid is produced, this fluid is produced. Well, it goes inside your bloodstream, okay? We call it creatinine, and your kidneys excrete it. It's a lot more sensitive, meaning there's not much of it, so the kidneys really have to excrete it well. So, if somebody's being suspected of having some type of renal disease or renal failure, creatinine is a better indicator that there's renal failure. Does that make sense? Creatinine is a better indicator. So what happens if they give you just a BUN and it's elevated? What does that mean?
Dehydration.
Usually dehydration. What if you have a patient that has a creatinine level that's very elevated? What does that mean? Renal failure. That's very important for you guys to know. Yes?
Does it still have to be high for it to be renal failure?
Yeah, but what I'm trying to say is this. BUN will be high if there's renal failure.
Regardless,
Yeah, but the thing is that which one's a better indicator? Creatinine is not going to be high if you have if you're dehydrated. BUN will. So that's why I said if I present to you a lab test and it's just the BUN and it's elevated, that's probably dehydration. However, if I'm giving, even if creatinine is by itself and it's elevated, that's potential renal failure. But usually we test both of them in conjunction. We also have something called creatinine clearance. We're seeing how much you're getting rid of in a 24-hour period. For this, you have to do a 24-hour urine specimen collection. Okay? So the creatinine clearance, how much creatinine is being cleared in 24 hours, also known as a GFR, or glomerular filtration rate. You guys should look this up, folks. Next time you guys go to your clinicals, they're inside your patient's chart, inside the lab works. Okay, the GFR is really important for you guys to know. GFR should be between 90 and 120 mLs per minute. That's average. Anything below that, something going on. This is essentially detecting how nephrons filter blood. How much fluid is passing by through the nephrons, and how much it's actually filtering out lets us know how the kidney's actually doing. Now, back to the creatinine clearance. You guys read about the 24-hour urine collection, right? How do you collect it?
After the first void, after the next void.
That means this: if Dr. Gonzalez says that, okay, we're going to do a 24-hour urine specimen to assess the creatinine clearance on a patient. I want to start it at 145. Okay, 145 starts, and I'm the patient, and I had to pee, so I go and I pee. What do you do with that urine?
Dump it.
You dump it out. You throw it away. That first urine in a 24-hour urine collection, you throw it out. The next one you collect. All right, so 24 hours. It's been 24 hours. And it's 1:45 tomorrow, okay? And I pee one more time. What do you do with that urine? You keep it. Does that make sense? The last voiding in the 24-hour period, you keep it. You include it in the 24-hour urine specimen. Does that make sense? Okay, please know that. I'm going to test you on that. Those elements that I just described right now. Want me to say it again? Yeah. Okay, I'll say it one more time. In a 24-hour urine collection, which would be a creatinine clearance, is one of those instances in where you need a 24-hour urine collection. The first voiding, the first time you pee, when the doctor orders it, you throw that out. You don't collect that. The last time you pee, you actually include that in the 24-hour collection. You usually have to keep it in ice, folks. So the patient's urinating in a urinal, you have to collect it in a special container and then keep it on ice. Keep it nice and cold so the integrity will maintain. Prostate-specific antigen, the PSA. This is what happens when your prostate gets bigger. Its byproduct is an enzyme called PSA, or an antigen, excuse me, called prostate-specific antigen. In other words, when your prostate gets bigger, it emits a little antigen and a little chemical, let's say, a little marker, and your kidneys are responsible for getting rid of it. So if your kidneys are damaged, your PSA may be elevated, and it doesn't necessarily mean that you have prostate issues. It just means that your kidneys aren't working well. Does that make sense? Okay. So that's why we also do a PSA. It's not too specific for renal function, but it's there. We also have an osmolality. It could be serum, or it could be urine. Let me explain what this is right now. It's how much fluid in relation to particulate, or to particles. And I've talked about this before. When we're talking about, can I borrow your soda? Can I drink some? Nice. It says in bold, it contains, why am I complaining about? I drink this all the time. All right, anyway, osmolality, folks, refers to how much fluid is in this container, in my blood sample or my urine sample, related to how much particles inside. So let's say my osmolality, it talks about osmolality, right? That's a term that we use to distinguish how much fluid, how many particles in relationship to the fluid is inside. So, if I have this amount of fluid, it's up to here, right? But I have a lot of particles inside, a lot of sugar, which this doesn't have, but a lot of phenylalanine is what it is. My osmolality is high. Okay? If I have a little bit of particles inside, my osmolality is low. Does that make sense? Okay? You guys have to know that. Let me give you an example. If you have diabetes insipidus, you folks remember diabetes insipidus? Okay. When you're peeing a lot, there's no ADH. You're just peeing a lot. So you're getting rid of all the fluid, but all the particles are still staying inside your body. So if I do a serum osmolality, blood sample, osmolality, somebody that has diabetes insipidus, and I have all this fluid, is my osmolality high or low? The osmolality is high in the serum, right? Because you're getting rid of all the fluid, all the particles stay inside the body. If you have a urine osmolality on a patient who's diabetes insipidus, all the urine's coming out, how much particles inside compared to that urine? Very low, so your osmolality is low. Same thing for specific gravity. There's another test that we take. It's called the specific gravity. Same thing. Okay? Does that make sense? Okay. Thank you. Yeah.
That's the both fluid and urine.
It depends what the doctor wants.
So, the fluid will be high and the urine will be low.
Well, for which condition?
What would we would expect, right?
What we would expect?
Yeah. So if I was giving an example. It depends. Let's say if I'm dehydrated, guys, listen to me. If I'm dehydrated, let's talk about specific gravity now. It means the same thing, right? Specific gravity, how much particle is in relationship to fluid? If my specific gravity of my urine is high, think about that. If it's high, my specific gravity of my urine is high, what does that mean?
Means
You're being the particles inside.
That I'm not peeing. That I'm dehydrated. Okay, because I have a lot of particles in relationship to that fluid. My gravity is high. It just means the particles inside are high. That's what it means. Okay? If my specific gravity is low, that means it's diluted. That means you have a little bit of particles, a lot of fluid out there. Okay, does that make sense? And it just depends if it's asking me for serum. Serum means blood, so you have to think about it. Okay, what are they asking me? Is it diabetes insipidus? Is it hyperglycemia? Which one is it? And that's how we'll know. Does that make sense? Okay. Specific gravity could be urine or serum as well. That's what I was talking about. We have something called the kidney, ureter, bladder radiography, or an X-ray that assesses your kidneys, your ureters, and your bladder. Sometimes when a patient comes in with non-specific pain of the general area, they'll take a KUB. Essentially, they'll put somebody flat and they'll take an X-ray of this whole area, see if there's any strictures or anything like that. Usually done to rule out certain elements. IV pyelogram. We give somebody an injection and it outlines the blood vessels in that particular area. We see if, first of all, if it's clearing it, and we see if there's any stones or any constrictures or anything like that. For an IVP, guys, you give iodine. So what do you assess for? Allergies to shellfish. Good. Retrograde pyelography, injecting contrast into the ureter. That's what this one is. You have to know what that is. It's injecting contrast into the ureter. It's going inside the ureter. So that's, again, contrast dye. What do we assess for? Allergies to shellfish. Okay? Allergies to shellfish. Voiding cystourethropy dye. Again, it's a dye. You assess for allergies, but this one's an X-ray, and they give you a shot with the contrast medium. So while you're voiding, they take the X-ray to see how your sphincter's working and all those elements as well. If somebody comes in with pain and they do certain tests, folks, and you can't figure out what it is, they'll start going down the list of all these different tests to see which one it is, where the issue's at.
Can you explain the one with voiding again?
Yeah, this is a shot that they give you in the vein, and it's got a contrast medium, a radioactive medium, and your body urinates it, excretes it. So they do an X-ray while you're urinating, and it's a several sequence X-ray. So it's like a little video almost of several pictures, and it's looking at how you're voiding because the marker's going through the kidneys, through the ureters, through the bladder, through the urethra, so it's mapping everything out to see if there's a stricture or any abnormal elements inside. What I want you guys to know is that all of these contain radioactive iodine. So you have to assess for allergy. That's the most important thing that I want you guys to remember. Man, switch slide.
The last,
Pardon me?
on the last bullet point I had.
Oh yeah, go ahead. These are in your book, folks, just FYI, but yeah, write it down, that's fine. You guys tired? I shouldn't have told you guys we're going early. You guys are expecting to go, huh? Folks, where does aldosterone affect the nephron? Distal tubules. Where does ADH affect the nephron? Collecting ducts. Where does Lasix affect the nephron? The loop of Henry. Okay. Henry. Mexican. Henry. Oh, that's not even Mexican. But I was telling the other class, like they have this disease called von Willenberg's disease. I'm like, why don't they have like Sergio's disease or like Hector's disease? They don't have any of those names. It's always like von Willenbrand's. Yeah. All right, man, switch the slide. All right, endoscopic procedures, folks, meaning anything that's going inside the body. This is an invasive procedure. You need a consent. Same thing with the radioactive dyes. You need a consent anytime you're going inside the body. These elements, folks, it's called renal angiography. We essentially put a little scope inside the blood vessels, and we can look all inside the tubules, what's happening. Renal venogram, same thing, but just for the veins. Computed tomography, CT, MRI. Anytime a patient has an MRI, folks, what do you assess for? Metal. Pacemaker, very important, guys. Ultrasonography, transrectal ultrasound. Why would we need a transrectal ultrasound for kidneys? Easier access. Why would you need a meaning going inside the rectum and doing an ultrasound of the rectum? Why?
See the prostate?
Yeah, because remember I talked about PSA being elevated? So if the PSA is elevated, you do a transrectal ultrasound, a truss, and sure enough, it's elevated. Oh, then it's not the kidneys, it's the actual prostate.
Is that the same thing as a colonoscopy, or is it different?
No, that one's a little bit different because a colonoscopy is a camera. This is an ultrasound machine. It goes inside through the rectum. It's pretty big. The diameter is pretty big. Well, just treat me for whatever you think it is. Treat me for both, just to make sure. All right, renal biopsy to detect any type of neoplasm, right? Any abnormal neoplasm, new tissue growth. Urodynamic studies, just a bunch of lab tests, folks. And cystoscopy, this one's really important. Okay, cystoscopy. Okay, this is when we go in with it. Usually we can go into through the meatus, little camera, and we can start looking inside the bladder. A cystoscope, a cystoscopy. Now, when you're going inside, you might cause some trauma. Very similar to like a catheter, right? It's not uncommon to see the patient urinate afterwards and have a little bit of blood. However, if it's after 24 hours, you report it, because that's abnormal. Does that make sense, guys? Please write that down. Cystoscopy, bleeding after 24 hours, report it to the doctor, report it to the RN. Man, switch the slide. All right, look at all those medications, guys. Look at all those medications. Look at all those medications. Tomorrow, I'll have a quiz for you guys.
No.
I will. Come on, guys. I give you guys a quiz every time we come back the next day. I try to have something for you guys. On Monday, I give you guys a test. Tuesday, just a quiz, just to kind of. Listen, guys. Tomorrow's quiz will only be on this. Okay? Tomorrow's quiz will only be on medications. Okay? Will only be on medications.
On all those?
On those medications that you see up there.
Only the ones in red?
Only the ones that you see up there.
What's the red one?
Only the ones you see up there, guys.
All of them.
Look, guys, these are medications here as well. Only on the ones that you see up there. And yeah, I'm only gonna quiz you on the ones that are red. All right, so listen. It's actually this. I feel bad because this quiz is gonna be too easy because it's just a couple of elements that I want you guys to remember. Thiazide medications. Thiazides. These are all diuretics in red. These are all really important. You memorize these, you won't have one issue on the NCLEX when it comes to your diuretic medication. When it comes to your diuretic medication. Listen, it says thiazide diuretics. These are also loop diuretics, folks. They work on the loop of Henle. However, they're like the diet version of your Lasix. They're just not as strong, but they do the same thing. They get rid of potassium. Okay? Thiazide diuretics, also known as hydrochlorothiazide. This is one of the medications. Thiazide is what's going to let you know. Thiazide is what's going to let you know whether it's a thiazide diuretic or not. It's going to have thiazide at the end. Hydrochlorothiazide is one of the most common medications that we give. Again, this acts where? On the loop of Henle, and it also depletes potassium. It's just not as effective as your Lasix. That's right. We have loop or high ceiling diuretics, also known as furosemide or Lasix. This one acts on the loop of Henle. It's very powerful. It depletes potassium, so you have to assess the potassium levels. What's the average potassium level? 3.5 to 5.0 or 5.1, depending on your policy, but that's the average right there. Good. If somebody is taking needs a diuretic, but they have history of hypokalemia, meaning low potassium levels, then you give them something called spironolactone or potassium-sparing diuretics. Okay. Now these probably look really foreign to you guys. They look super foreign. You're like, wow. That is. My advice is write each of them 30 times on a sheet of paper. I mean, really, go back to like elementary school. I mean, seriously, last night I was reading a book on public policy. On public policy, you know how stimulating that is? But I still read it, and what I did was every time I would come up on a word that I wanted to memorize, I would just keep writing it over and over and over. What I would do is I would type it. I would text it. Okay, that's how you memorize these words, folks. It's one of the only elements that it's a little tedious, but it'll help out. Spironolactone, folks, you get to somebody. Shh. You guys have a question? All that.
Well, I was just asking about this.
Spironolactone, aldactone. These are different types of diuretics that don't get rid of potassium. So, like if I'm taking Lasix, right? One of the complications is hypokalemia. We have to look out for low potassium levels. I'm going to have cardiac dysrhythmias. So if that's a danger, if that's an issue, then what you do is you give someone spironolactone. This one doesn't get rid of potassium. Okay, and
Why
that's
don't they just do that across the board? Give it across the board.
because it's not as strong as Lasix. That's why. That's why.
Both of the thiazide and the hydrochlorothiazide is for, I don't know how to pronounce it, those both deplete potassium, right?
Yes, they both deplete potassium. Your thiazides and your Lasix, they both deplete potassium. But hydrochlorothiazide is just not as effective as Lasix, as your furosemide. Yes?
Stretch.
Yeah.
So why we are not going to give them directly potassium sparing diuretic?
Because it's not as effective. If somebody has a lot of edema and you give them spironolactone, and you give them spironolactone, it doesn't get rid of the fluid as well as you would with Lasix. So what they would do sometimes is they would give a little bit of Lasix and give a higher dose of spironolactone. You see what I'm saying? To not get rid of that much potassium. But that's why they don't just do it across the board. You have something called osmotic diuretics. Just know that osmotic diuretics just gets rid of water, guys. Just gets rid of water. Usually affects it, I'm assuming, at the collecting tubules, because that's where the release of water happens, the reabsorption of water. So we're stopping it, getting rid of fluid. It's called mannitol. Know that medication, mannitol. It's called an osmotic diuretic, meaning it just gets rid of water. That's it. Carbonic anhydrase inhibitor diuretic. That's another type of diuretic. It's not that strong. It's not really even used that often, but it's up there. Acetazolamide. Acetazolamide. Know that medication as well. These are all common diuretics, folks.
What is this one?
This one just works on another. I don't even know exactly how it works, but there's something called carbonic anhydrase, which actually helps in getting rid of water, in reabsorbing water. This one blocks it, hence you get rid of water. It's also, it just gets rid of water, guys, just water.
The same thing as mannitol?
very similar to mannitol, except it works on this other element, on this other enzyme that's called carbonic anhydrase. That's what it works on. So it stops the reabsorption of water. All right, medications for UTIs, folks. Any type of antimicrobial or any type of what are they called? Antibiotics. Okay. Quinolone. Anti what? Antiseptics. Folks, when it comes to UTIs, what's gonna really depend on what medication do we use?
Bacteria.
The bacteria. So when we do a culture and sensitivity, that's when we're gonna know whether we use erythromycin, penicillin, probably not, amoxicillin, Cipro, all those different medications, folks. It's just really gonna depend on what the pathogen is. I'm only gonna test you guys on the red stuff. Okay. But before I move on, though, what's a common complication of any antibiotic medication?
Diarrhea.
Diarrhea. For antibiotics. Antibiotics. Diarrhea. Pardon me?
No, not infection.
Rebound infection you talking about?
Yeah. UTI.
Yeast infection.
Oh, yeah.
A side effect of antibiotics? Oh, yeast infection. That makes sense. You have to really over-medicate somebody, but yeah, that makes sense.
Tomorrow. I never finished.
Let's talk about types of catheters, guys. 5 more minutes, I'll let you guys go home. 5 more minutes, I'll let you guys go home.
Okay, continue.
The ones in red are the ones you guys have to know. Simply, not only because they're on the test, but because they're most common. I've used all of those. I've seen all, well, not like used, but I've seen all of those. A Coude catheter, folks, or a Coude, or a Coud, or however you want to pronounce it. That one's, if you think about, excuse my middle finger, but if you think about a catheter, right? And then this is what happens with the catheter, with these ones. You see how it's angled? It's angled if somebody has hypertrophy of the prostate gland. If the prostate gland is squeezing on the urethra, when you go inside that catheter, if it's a regular French tip catheter, it's just not gonna go inside. However, these ones are bent, and they're bent, and it's a little tougher material, so it actually passes on through. Does that make sense? That's how these are. Then you have your Foley catheters, your Malakoff. These are mushroom catheters. These ones have the tip looks like a mushroom. They don't have a balloon. Because this one, it goes through the urethra. Okay, painful. But once it comes into the bladder, the mushroom part like opens up. Or actually, well, after it passes through the tight lumen of the urethra, it opens up, and that's what actually keeps it from coming back inside the bladder, the urethra. Does that make sense? That's a mushroom catheter. Robinson catheter.
How do you take it out if it doesn't come out?
Well, it collapses within itself as well.
Okay.
Yeah, it collapses within itself as well. Yeah. A whistle tip catheter. Let's talk about the ureteral catheter. That's a catheter that goes inside the ureter. Okay. Does that make sense? Okay. Why would you need a ureter catheter? If you can't get into the bladder, or if the bladder's not even there. Okay. Cystostomy, vesicostomy, or suprapubic catheters. These are all types of collection devices, folks, that are placed on the bladder, okay, on the side of the bladder. Little bags. They bring up the bladder and they attach it to the pelvic wall, and they put like a little bag, like if it were an ileostomy, but it collects urine. You can do that as well, or you can do what's most commonly used, a suprapubic catheter. Yes.
I've seen the super pubic, well, I've seen a few of them, but the super pubic ones seem like almost irritating. You notice that it's like, feel it there.
Yeah.
If your bladder's like, you know when you have like an infection?
Yeah, because
It looks like you can feel it.
what ends up happening is that, well, I'll talk about it in a bit. Hold on. Suprapubic catheters, and then we have the condom catheters. So, yeah, remember I talked about this patient This is a coude, by the
That
way.
they tied it up.
Yeah, the patient was incontinent. They put a condom catheter on, but they have these two sizes. You have this one, and you have this little bitty one right here. Well, even this one kept falling off the patient. So what they did was the CNA was very clever, or I'm assuming it was a CNA, and she put tape around the penis, and that thing was collecting urine very well. 3 days later, the urine output was great, the penis was gone. It was necrotic. She tightened it so bad it cut off the blood circulation. So they had to do an amputation. Now, how do you do a catheter for this patient? For this particular patient, a suprapubic catheter was an option. So they perform an incision in the suprapubic area. Okay, a doctor does this, folks. A surgeon does this. We don't do this. Okay, he or she initiates the surgical procedure, puts in the catheter, puts in the lumen is very thick too, by the way, of the suprapubic catheter. A lot of issues, a lot of drainage coming out, risk for infection. It erodes the tissue because you have the rubber, the rubber or the latex that keeps irritating the skin. So high risk of infection, in other words. With the suprapubic catheter, we as nurses, we can replace them. But when it comes to the initial placement of one, it's the physician or the surgeon. Okay, guys, please remember that. So yeah, condom catheters, coude, and that's your whistle tip. Yes.
The other visit, we were at the yard, and there was 3 other nurses that were trying this after I did, and they couldn't get through, but the catheter wasn't going, I mean, it was gonna go, it was in all the way, and then there was like a little ball at the end of its penis.